So hello all, many thanks for attending tonight's session on the primary care webinar with HE. So it's great to see so many people attend. We've currently got 63 people and we are expecting around 200 this evening, so we might get a few more numbers throughout the course of this evening. I just wanted to let you know, you might have already heard of the conversations beforehand. We've had a few technical issues with GoTo, so unfortunately we won't be able to see our speaker, Amanda Hensman-Crook from HE, but hopefully we'll be able to hear her clearly. And then we are going to all put our cameras on a bit later on when we come around to questions, so you'll be able to see the others that are part of the session this evening. Just to let you know, if you wanted to watch any of the previous webinars, we've done 2 previously. You can find the link to these in the email that you were sent out today. And just to briefly introduce myself, for those of you that haven't yet seen the previous webinars, I'm Eleanor Johnstone, the Professional Practice Manager at the BDA. I'm also a dietitian by background, and I'm supporting dietitians working in primary care across the UK. So one of the projects that we're working on is supporting HE to develop the first contact practitioner to the advanced practitioner dietetic roadmap for primary care, which is what we'll be discussing in more detail this evening. The roadmap not only supports the safety for patients and dietitians in primary care, but it also helps to showcase to other professions what we can achieve. So what a dietitian working at advanced clinical practice really capable is capable of, and not just what others assume that we can do. So really exciting times in terms of primary care for dietitians. We wanted to keep the session really informal to ensure that we can address as many questions that you might have as possible. So we've kept to a short presentation from Amanda Hensman-Crook, who's HE's AHP National Clinical Fellow, and she's a consultant MSK physiotherapist. She's going to share the national perspective, and then we'll run a few polls and follow on by opening up to questions. So Amanda will be supporting with answering these, along with Tanya Rumney, who's an advanced practice dietitian and HE ambassador, Sue Meredith, who's a clinical lead paediatric dietitians, dietetics and enteral nutrition, and chair of the paediatric specialist group, as well as Steve Austin, the National Employment Relations Officer at the BDA. So I'd just like to start by, first of all, starting the presentation and then handing you over to Amanda Hensman-Crook, who will present on this.
Right, thank you, Eleanor. Hello, everybody. Good evening. It's lovely to have so many of you on here this evening. So my name's Amanda Hensman-Crook, as Eleanor has said. So I'm responsible for the AHPs moving into primary care as first contact practitioners and advanced practitioners in terms of their training, supervision and governance. So I think I'm just going to do a short presentation just to set the context for the evening, although Eleanor has eloquently already started with the discussion around that, which thank you, Eleanor, that was really good. Can we have the first slide, please? So I always like to start with why. Why are we doing this? Because, you know, people are wondering quite often, sort of like, we're already doing our jobs and we've already got our skill sets and we already work in a certain way. Why would we now be working in primary care, and why are you introducing a capability framework for primary care specifically? So if we go historically, general practice was struggling with capacities, and we knew this back in 2014, 2015. So that really we needed to see how we were going to help support primary care as GPs were leaving and there were fewer GP trainees coming through to become GPs. So a scheme was introduced called the Additional Role Scheme under the Contract DES to get 26,000 clinicians into primary care to help support the GPs. So part of that 26,000, we have 5 AHP professions moving into primary care under this scheme, one of which is obviously dietitians. We've got occupational therapists, podiatrists, physiotherapists and paramedics moving in as well. So the reason that we've developed this framework is not to be difficult or to make people jump through hoops. It's really to assure patient and clinician safety. It's a very different environment to work in primary care. And you're working with undiagnosed and undifferentiated conditions there, so there's a higher risk. And working in primary care, we don't have the whole multi-professional team around us, so it's really important that we have clinicians in there that are experienced and they've got proven capability to be able to keep our patients safe. We need a clear offer to primary care at this level of practice. They don't really know AHPs in primary care so well. You might have had physiotherapists working their hands-on in the past, but they're not working in that capacity now. It's a diagnostic clinician, so it's different. You've had paramedics around in primary care, but again, they weren't working in this particular scope of practice. And of course, there's been very few dietitians and OTs and podiatrists working in the primary care environment. So we need to be really clear about what it is that we're doing and what we can offer to them. We wanted standardisation of practice at master's level across all of the AHP professions to offer parity. And of course, by having the right people at the front end of the pathway, it assures impact across the whole of the healthcare system. So by having our very best, most experienced clinicians sitting at the front line, then it streamlines everything moving through the whole system to make sure that the right people are getting to the right place at the right time. It's to improve recruitment and retention as well. It's really important that we are looking after our staff by having a framework and a clear training pathway with supervision wrapped around it for support. Then hopefully we're going to encourage people to stay in their workspace. And also, if you're moving towards the advanced practice part of it, as an advanced practitioner, you work across the whole pathway. So it's really nice to think that if you want to, you can aspire to become an advanced practitioner. But if you don't want to, that's fine. You can jump off at first contact level. That doesn't matter, but it gives you options. So Health Education England are communicating with all of the 5 professional bodies, and the BDA are helping to support us and Health Education England to achieve this and the roadmaps. And we all work really closely together, and of course, engagement with wider stakeholders, with dietitians in your case, and also with our patient population has been super important to achieve this too. Next slide, please. So this is what I call my capability caterpillar. It's just a nice, easy way to explain where about FCP sits in a pathway. So what you're looking at is an educational development pathway. And this shows you what it looks like from when you're first registered, right on the left-hand side of the green bubble. And it's the minimum length of time to get to each level of practice. So at the top, we've got the years of expected working before you reach this level of practice as a minimum. And at the bottom, it tells you the academic attainment that you might get at each level of practice, or what's required for each level of practice. And then you've got your learning gradient, which is the area that goes diagonally across the whole thing. That's the lifelong learning gradient. As you can see, it is a gradient because you start off from less experience and less knowledge and less working. And over time, you're building on that as you go along, building up and up and up and up and up till you get to your final destination, which can be at any of these bubbles. So you start off as a registered clinician, as a novice practitioner. So people often say to me, well, I came out with a master's degree as a dietitian or a physio or whichever profession they're doing. Why can't I go in straight away to be a first contact practitioner? Why do it have to be 5 years? Well, it's because it's only for experienced clinicians. You have to get the years under your belt. So you start off, regardless of what academic attainment you get. When you first register, you're a novice practitioner. You're only just beginning. You're just learning how to do the job. So you might academically have achieved even a PhD. You might come out as a doctorate if you're really smart, but you still haven't spent the time with the patients, with the system, building on your knowledge, skills, and attributes into the development into an experienced practitioner, which is experience and clinical based as well as the academic attainment. So next slide, please. So this slide shows us about what is master's levels practice. They kind of divide. This is the subject specific stuff that you'll be probably more familiar with. This is the academic side of it. So it's about in-depth knowledge and understanding informed by current research, your critical awareness of issues and developments, your complex clinical reasoning, critical thinking, and research understanding. So your ability to review and carry out research. Really important academic things, that you're looking outside your graduate learning and you're starting to look more around evidence-based and pathways and frameworks and national guidelines and local guidelines and things within your work. And obviously at the same time, you're also developing your master's level skill set in terms of your clinical practice. Next one, please. So the bit that people forget about, I think, is that you also have generic abilities and skills. These are your, when we talk about knowledge, skills and attributes, these are your attributes. So it's a range of generic things that you're able to do at master's level practice. So it's really important when you're looking for people at this level of practice that they're able to use their initiative and take responsibility. They can solve problems in a creative and innovative way, make decisions in challenging situations, continue to learn independently and to develop professionally, and to be able to communicate effectively with colleagues and a wider audience in a variety of media. So these, alongside the academic abilities, the specific abilities, really important to make a rounded person who's working at master's level practice, whether it's first contact practice where you're working at master's level just in the clinical pillar, or whether it's as an advanced clinical practitioner where you're working at master's level across all 4 pillars of practice. So next stage, please. So there's 2 different ways that you can become a first contact practitioner. You can either go down the portfolio route or you can go down the taught route. Now, both routes are the same, and the knowledge, skills and attributes document that is the master's level clinical skill set that you have to attain from the roadmap. It's exactly the same. The knowledge, skills and attributes document sits right in the centre of all the HEI modules. So all the HEI modules are mapped to this. And for the portfolio route, you're mapping your maybe master's degree or level 7 modules, or if you don't have any of those, your evidence against the knowledge, skills and attributes document. So as you see, as you go down here, it shows you about what supervision is required for either the portfolio route or the taught route. So for the portfolio route, we're developing nationally a group of supervisors called roadmap supervisors, and they're specific for signing off both stage 1 and stage 2 that we'll talk about in a minute of the roadmap. So these people have all got master's degrees themselves, or they've gone through the training and become a first contact practitioner or an advanced practitioner. So we have to keep it at a high end, because in effect it's educational supervision, because they are looking at a portfolio of evidence and they're marking this portfolio of evidence and they're saying, yes, you are an equivalent to a master's degree. Okay, so you're not getting a master's degree at the end of it, but you are recognised as having an equivalence to working at master's level. Both of these taught routes and portfolio routes end up on a directory once you've completed both stage 1 and stage 2 at the Centre for Advancing Practice as a recognised first contact practitioner. And once you've done that, you can do a top up to advanced practitioner. So the stage 1 part is the academic component. So it's really important that we know that academically a clinician is able to complex clinical reason. They're able to draw on current research. They're able to look at guidelines, national guidelines. They're able to not just look what's in front of their nose. They're able to build in the whole broad picture. So primary care is really different to working in secondary community care, because you might have your superpower. So if you're a dietitian, your superpower may be, say, it might be around irritable bowel. Forgive me, I'm not a dietitian, so if I've said something wrong, just bear with. So if that's what you do and that's your superpower and that's what you're really experienced in, it's not just about looking at. Now, if you've got somebody coming in with an irritable bowel syndrome, obviously there could well be a mental health aspect to that. So I would expect you to be able to identify that person's got a mental health concern around that. They might have anxiety with that, and know which pathway and where the support is in the system for you to be able to push to be able to put them on the right path to be supported and managed properly for their anxiety. And if that person happens to be elderly, are you able to recognise frailty? It's really important in primary care to be able to look at the person as a whole thing, not just as a person with the presentation in front of you. You've got to remember that in primary care as well, you're seeing a presentation, not a diagnosed condition a lot of the time. So your person would be coming in this instance, they'll be coming in with tummy pain perhaps. They won't be coming in with a diagnosed IBS. That would be up to you to be able to do that. So that's the academic. You can show that in academic writing. And then the stage 2 part is with your supervisor, using work-based placed assessment toolkit, which is the same way that GP trainees to be GPs. It's exactly the same thing. What they're doing then is you're testing your academic knowledge in practice. Are you able to apply that knowledge that you've written about into practice, into the clinical setting? So with the portfolio route, you do the stage 1 before you move into primary care, ideally, and then when you move into primary care, you do your stage 2. If you do an FCP taught module, it's done all at once and you come out fully cooked after your FCP master's module. Once that's completed, you just do regular supervision. So the supervision is relatively high whilst you're going through the teaching and the learning, because you're being supported to get through it either way, taught or portfolio route. But once you come and pop out the other end, then you just go back to your normal clinical supervision, CPD supervision that you would normally have as a dietitian. Once you have popped out the other end, though, it'd be really good if you can then go and do the 2-day roadmap supervisor's course. Next slide, please. And then you too can become a roadmap supervisor, so that you can support other dietitians and multi-professions through the portfolio route. The roadmap supervision and verification supervision course equips you to not just supervise dietitians, but you can supervise the whole multi-professional team, because what you're marking them off on is are they working at master's level practice. You're not checking to see that they're able to do an assessment of the knee, for example. That isn't what it's about. It's about, are they able to look that broadly? Are they bringing into the local pathways? Are they, what's their engagement with the patient like? Have they safety netted? Have they identified red flags? So it's around that kind of thing, really. So I'm going to put a plea in right now. So if any of you out there, any dietitians out there, have a master's degree already, you are eligible to become a roadmap supervisor now. So if you feel willing to do that and you want to support this and you want to support other dietitians as an experienced dietitian, then you can access a 2-day roadmap supervision course, which are being run digitally by the training hubs. So if you go on the landing page, which I think that Eleanor may have put that link out to you in your invites anyway, if you go onto the roadmaps landing page, there's a list of dates of training courses that are being run. So please, please, please become involved. We'd love to have dietitians as part of the roadmap supervision infrastructure. So I'm going to leave it there so that we can move on with the next speaker.
Hi, I'm Amanda. Thank you so much for sharing that. That was really helpful, bringing together the background to the project, but also the different routes for first contact practitioners. Hopefully, I'm still sharing the slides. I just wanted to let everyone know where we're up to with the roadmap. So with the dietetic one, we're producing ours side by side to the Royal College of OTs. So it's likely that they'll publish theirs first, and hopefully we'll publish ours September time. We went out for a consultation, so thank you to all those that supported with that consultation and gave us feedback. We've gone through every piece of feedback individually, and our roadmap steering group have supported us with that to make changes to the roadmap and adapt that. So we're also doing lots of other things to support some of these roles. I just wanted to share some of that with you. First of all, we have contacted the insurance company, and obviously they're aware of the moving towards undifferentiated conditions. But what we'd like to hear from you is that if you are doing anything advanced or anything extended within your role, we'd like you to get in contact with us, let us know, and then obviously we can have two-way conversations with the insurance company about anything that's new and innovative and not usually would be seen as dietetic practice. So if you are doing something unusual and something extended, please email us and let us know. I've put the email address up there, so it's insurance@bda.uk.com. let us know what your role looks like. Are you working as first contact practitioner? Are you also doing supplementary prescribing? Just to clarify, supplementary prescribing is already covered by insurance, and so is the undifferentiated diagnosis. It's not that they won't be covered, but if you're doing something outside of that, we just obviously need to check that through with them. We've also commissioned a training and education review. So we commissioned, first of all, one of our members to look at online, like HE's free online training, and they've sent us some recommendations based on that. So we will put that up on the website in terms of what training and training from HE, but also elsewhere you might want to consider as part of these roles. And then separate to that, we've also commissioned an education review looking at all master's level education, which will include primary care. So for the roadmap, what kind of courses are already out there that you might want to access, but also what might be missing that we might want to consider speaking to our HEIs about developing. Amanda mentioned becoming a supervisor, and the people that train the supervisors are the HE national trainers. There is a course Friday the 13th of August and Friday the 20th of August. I'm not sure if there are any spaces left on these, but if someone has a relevant master's level qualification, then they may be able to be eligible to be a national trainer. And then the national trainers are who then train the trainers to then supervise the members. So if you were interested in that, so you would be training the supervisors, then please contact Denise at HE directly. Amanda also mentioned the HE roadmap landing page. Now there's loads of really useful resources on there. I just say check it out, have a look at all the stuff that's on there. And as and when we go along and we create more resources, we'll be sharing them with HE, who will pop them on that website. But there's lots of multi-professional things as well that you might find really useful. And then there's the BDA First Contact practitioner webpage that I've popped the link to there as well. So some of the resources and just supportive information that we already have on there, along with the last webinars. And also we had quite a few questions at the last webinar that we didn't have time to answer. So we've popped those questions and answers on that page as well. And if in the meantime you have any other questions or queries that you want to get in touch with us about, you can always email the BDA, info@bda.uk.com. Once we have launched the roadmap, as I mentioned, we're hoping to launch that in September. We'll have a follow-on webinar, so it's likely to be sometime in October, to then again discuss it and go through some of the questions that you might have following that. So just keep track on that page, but also we will email all of you that have attended today to let you know when that webinar or the next webinar is launched. So if you want to sign up, you've got a link to that. So I'm just going to share some of the polls with you now and get some answers to some of these from you. So first of all, and I hope this works, we've got a poll asking you, where are you based? So if I launch that, hopefully it comes up on your pages, and we'll just give you a few moments to fill out your answers to that one. So we've got lots here from England, a few from Scotland and Wales. And just to let you know, we're just waiting a few more minutes and let you have a bit more time, but just to let you know, obviously this is Health Education England who's been leading on this piece of work, and we've been supporting it. We are also supporting primary care within our other home countries, so Northern Ireland, Scotland and Wales, and we're looking at how do we support roles within those countries as well in primary care. So we will be sharing some updates on that as well. So I'll give you a few more seconds for anyone who hasn't answered. We've got 86% votes. Okay, 87%. I think I'll close and review. So we've got 92% from England. We've got no one from Northern Ireland. We've got 4% from Scotland and 4% from Wales. So thank you very much for completing that one. Our next question is, are you working in primary care? So I'll launch that one. So you might just be interested in working, you might be considering working, you might be thinking about employing someone. There's quite a lot of possibilities with this one. We've got 60% voted so far. Majority at the minute are working in primary care. 76% voted. Leave it open for a few more moments. Okay, so close that one. We've got 58% said yes and 42% said no. So the next one, who are you employed by? Just going to launch that. We know that there are lots of different routes that people are employed by, especially in England. When we were added to the GP contract in 2020, it meant that GPs or primary care networks can then get money back. So as a part of the additional roles reimbursement scheme for dietitians in primary care. So lots of dietitians have then been employed through this route. They might be employed directly by the PCN or by the nutrition and dietetic trust that is local to that PCN. So primary care network, that is. Or they might be working on a freelance basis. So a few more moments to let some others vote. Got over 70% voted so far. Okay, so we've got 3% freelance, 22% primary care network, 42% the nutrition and dietetic trust, and then we've got 33% other. And the last question is, what type of role are you doing? So are you doing the first contact practitioner type role, where you see the patient first before anyone else has seen them, likely that they've been triaged to you from a receptionist? Are you doing more of a dietetic led, so more of the traditional role, where they might have seen the GP first or another healthcare professional who've diagnosed with the condition and then referred them on to you? And then there's some other as well. So we've got over 80% voted here. We've got 3% doing the first contact practitioner type role, 67 more of the dietitian led, and then we've got 30% doing other. So I'll close that poll. Thank you very much. That's really helpful to know a bit more about the workforce in primary care. So that's really useful. Thank you so much. We also have, that you can find a link to on our webpage, a discussion forum. So for anyone who are in these roles or considering working in primary care, we have a discussion forum to share ideas, to share a bit about your role, and to ask questions for others. So again, if you want to join that discussion forum, head over to our website and you'll find the link to it there. So at this point now, I'm just going to introduce all of our other speakers to come up and support with some questions. If you don't mind popping your cameras on, that would be amazing. And I'm going to check if we've got some questions. That was a good reminder, so I should have said at the start, if you have some questions, if you pop them in the questions box. I think we've had a few. Yeah, we have. Brilliant. Okay. So whilst I try and navigate these questions, my box has just been hidden for some reason. Sorry, I'm just trying to find these questions in a better way. Okay, here we go. So first question, in secondary care, we also look at the patient, more of a statement this one, we also look at the patient in a holistic approach. So yeah, absolutely agree with you there, and that holistic approach can definitely help in primary care. So you're not just thinking about that one condition that you might be managing, but you're also thinking about comorbidities and other conditions that might present similar to the one that person's been diagnosed with. Is this role linked to banding? If I start to answer this, and then obviously Steve and Amanda can jump in with anything else that they want to add in addition to that. So on the GP contract, there is the ROS reimbursement scheme linked to banding, pay banding, but it's not the same as agenda for change banding. So for example, primary care networks can claim back up to pay banding 7 for dietitians, or 8A if they're advanced practitioners in primary care, and that's just the same rate of pay, but it doesn't equate to terms and conditions. They are separate in primary care. They don't come across like they do in NHS trusts. So that's just something to be mindful of and something to consider when you're signing contracts and when you're agreeing to jobs within these roles. If you are employed by the trust, then they'll likely then keep you on the agenda for change band 7, because you'll be employed by that trust and then kind of contracted at a service level agreement with the primary care network. Is there anything else to add, do you think, to that, Steve and Amanda?
I think, Steve, you're on mute.
We can't hear you, Steve. We still can't hear you. No.
Oh, yeah, it's just told I'm unmuted. Basically, the funding is equated to, but it is not the same. So it's not agenda for change. It's not agenda for change pay bands or equivalent. They will have their own pay structures that were somewhere in the region of that sort of money, but it won't be. So if you're in an NHS trust on agenda for change terms and conditions, it will be different and likely to be less.
Thanks, Steve.
So from my perspective, from Health Education England perspective, for an FCP, what we do things the other way around. It's about being reimbursed for your capability. So once you've proven capability at master's level, you should not be paid less than the agenda for change equivalent of band 7. And if you're an advanced practitioner working in primary care, then you shouldn't be paid for any less than the equivalent of a band 8A.
Thank you both, that's really helpful. We've got another question. I think this relates to the supervisor training. I have a master's degree, but would I need to do this for free? Would I get paid for this? So if you were the supervisor, you're not reimbursed for that. We would hope that everyone in time becomes a supervisor and helps others, a bit like we would expect that for student training as well. So part of HCPC and supervising other members of staff, you wouldn't get paid for that part of it. You would, however, if you were the national trainer, so if you were advanced practitioner or you had that master's, relevant master's level, and you were to become a national trainer, you do get reimbursed for the 2-day courses that you run there. That's correct, isn't it, Amanda?
That is correct. And we're actually looking for dietitians that are willing to do the training to be a national trainer. We're looking for OTs and dietitians and podiatrists in particular at the moment. We already have physios and paramedics that are national trainers, and nurses and GPs. So it'd be really nice to see some of you other allied health professions trailblazing, to be honest. It'd be lovely. And going back to being reimbursed, you've got to remember that it's for the FCP and AP are for experienced clinicians. It should be part of your job plan as an experienced clinician, and it's kind of Giving back, it's something that we should be doing at the top end of our profession, helping to support others coming through a pipeline. So when you are moving into primary care and when you're negotiating your terms and conditions, you shouldn't really be doing 100% clinical. It's really worth negotiating 80% clinical, 20% non-clinical, so that you have space to be supervised and to supervise others.
Thank you. We've got another question. Is it a full MSc qualification for FCP or one module? Amanda, are you happy to answer that one?
Of course, yes. The FCP is a master's module. It's generally 40 credits, and you can use that if you're doing an ACP masters, for example. You should be able to pull those 40 credits from your FCP module into your masters module, so that those 40 credits sign off from your total number of credits needed to be an advanced practitioner. And the same with the portfolio route. You don't get master's credits for that, but it's seen as an equivalence to that, but it's not a full master's degree. You're already working or should be working at a master's level of practice clinically, so that's where the master's part comes from.
Thank you. As well, you might do courses aimed at that level 7, like supplementary prescribing, which again are modules, master's modules, but not a specific master's degree. I'm just Sue, I know you were having to leave, weren't you? I think about 1:45, is that right? So Sue's come along to support with PEDS questions because we were a bit scared to answer those. So if you have anything PEDS specific, please, while we've still got Sue, pop them in the chat, pop them in the questions. If there are anything that come after that time, then we can obviously still send it to the specialists, and I'm sure they're more than happy to support that. Okay, I can't see any specific PEDS ones at the minute, but I will keep checking back. Okay, so just a comment here. I think a lot of services will go into primary care in the future from secondary care. So trying to treat people, it's more preventative, and trying to treat people closer to home, isn't it, to stop them going into that secondary care or progressing onto that. We've got a question, what do you mean by a roadmap? So really good question, and there's a link to the previous webinars in the email that you got sent out. So if you're unsure when we talk about the roadmap, I'd say go back to those and have a listen through. Basically, as part of all of these roles, all the AHPs that have been brought into primary care on the GP contract are all developing roadmaps. So it's a list of knowledge, skills and attributes, the capabilities behind those are what we can expect. Level 7, what do we expect the capabilities to be, the knowledge, skills and attributes for these roles. So it lists them as a bit of a checklist to support people, but it also, there's lots of content before that goes through what supervision will look like, what the route looks like, and then also loads of tools and resources to support you to collect some of this evidence. So the roadmap pulls all of that together. So it's a document to support what does this look like in practice, how do you access supervision, what resources are available, but also what capabilities will be needed to achieve first contact practitioners status or advanced practitioner status in primary care. Amanda, do you think that covers that question?
It does, yeah. It's an educational training framework. So exactly what Eleanor said is what is on the tin. And what's really important just to note is that the roadmaps for all the AHPs are exactly the same. The body is exactly the same. It's just that instead of saying paramedic, it says dietitian in it or OT in it. What's different is your knowledge, skills and attributes document and the documents that it's been mapped against. So basically it's the same pathway, same level of practice, same supervision, same governance, but with your own superpowers in it.
Thank you. Thank you. And as well, if you Google, I'm sorry, I've not got the link to show you right now, but if you Google paramedics roadmap, for example, you can find their example of the roadmap and you can have a look at that. It just gives you an idea of what ours will look like. It's obviously going to have our own knowledge, skills and attributes. I see a question here for Sue, so I'm just going to quickly jump on this, and I know you've only got a minute left. So do you know if this paediatric specialist group will start providing resources in electronic format, has been the question.
So this is related to the resources that we already develop in the paediatric specialist group.
I guess so. Yeah. I think so.
Yes, yeah. We're constantly reviewing our resources all the time, and as you know, we've relaunched the general leaflets that we provide. We recognise there's a role really for electronic resources, and particularly things like short educational webinars and that sort of thing for parents to see, and also for children and young people to watch as well. So I think that will be a good move forward. As you know, everybody on the paediatric specialist group is a volunteer, so they are doing this in their own time. So it will take us time to develop these resources. But if anybody listening today would like to come onto the committee and work with us on resources, then you'd be very welcome to.
Brilliant, thanks Sue. Yeah, and if anyone is interested, if you email info@bda.uk.com, and we can signpost that to a paed specialist group. So yeah, it's good. Absolutely. Like Sue said, everyone's volunteers. Everyone has come this evening in their own time to support with this. So we massively appreciate that. And obviously, all of our specialist groups, it's the same thing. So it's having the resource to then make these changes, isn't it? But thank you so much, Sue, for coming along.
Thank you for inviting me. I'll leave you now.
Thank you. Bye. I think we had another question as well, which might be aimed at Sue, but we'll come through the list so I'm not missing any. You just come on to. Okay. Is there an expectation that every dietitian working in a PCN role will become first contact practitioner, or will some dietitians remain in a traditional role? And is this decided by the PCN?
Okay, Amanda. So under the additional role scheme, you're expected to be working clinically at master's level. So that, in essence, that is what a first contact practitioner is. It isn't necessarily something really wildly different to what you would do in terms of skill set in secondary care. It's just that you're expected to look more along the personalised care type of lines, and where you might be only focusing on just one thing in secondary and community care, you might be looking at a much broader base. So so realistically, that's the case. So yeah, I've forgotten what the beginning of the question was now, because I've gone off on one in my head. You know what I'm like, Eleanor, sorry.
Oh, no, don't worry. So is there an expectation that every dietitian working in a PCN role will become FCP?
So under the additional role scheme, you should be working at FCP level. So if you see it as a level of practice rather than a job role, do you know what I mean? So you are expected to be more diagnostic. But for under that scheme, yes. But if you're employed directly outside the additional role scheme, then you could be employed as something that is not working as a first contact practitioner. And because they're private businesses, they can employ outside the additional role scheme as well.
Yeah, I think that also answers another question. Do we know if and when the roadmap will be mandated? Many of our local PCNs do not see the dietitian as potential FCP and see it as in-house dietitian. So that's the same answer as Amanda's just the same kind of question. In terms of the GP contract, there is stipulation that if they want to the roles reimbursed, so if you've been employed that way, that you'd be working at master's level, which can be evidenced by the roadmap. But as Amanda said, if you weren't employed under that route, then the primary care network could make that decision as to exactly what your role looks like. Obviously, that's something that you've agreed with them directly.
Absolutely, and it's important to note as well, because we do know that in certain different populations they have different population need. So it could be that even under the additional role scheme employs an FCP, you might be employed because you've got a particular superpower that they want, whatever that might look like in terms of the dietitian's role. But that's fine. It's fine that you're being employed just for that one thing. But if you're being employed under the additional role scheme because you're working in a master's level practice, we would expect you to be looking outside that as well, and educating the GP practice on what a dietitian could be. You're the ambassadors, really. You're the ambassadors for dietitians. And you've got to remember that primary care don't understand what you can do. They don't understand your skill set and what you can achieve. So this is a really great opportunity for dietitians to move into primary care and to show off exactly what you can do, because you've got an amazing skill set that's really, really beneficial to primary care, but they might think that you can only just do one thing. So go out there and show them what you're made of.
I think that's a really good point. Anecdotally, when I've been speaking to people, that's the feedback that I've had, is that the professions don't necessarily know what we can do, and the first thing that might come into their head is potentially weight management. So then that might be what they choose, but actually they're unaware that we can do everything else as well. So I think it's really key that we do educate others on what we can do, and BDA recognises that we've got a big role in that as well. So we're looking at how do we increase the understanding of others of what we can offer. We've got a post saying, I tried to post in the primary care forum but had difficulties, it didn't seem to post. So if you get in contact with us directly at the info@one, we can check that out and just make sure it's working correctly. We let people know we've automatically signed them up to receive alerts on posts that go out there. So if you're part of the group, in theory, your post should then be shared with all the other members so that they can see that. So if you're having difficulties, please get in touch and let us know. We'll look into it for you. Do you think that the inability to independently prescribe will limit the scope for dietitians? Tanya, I don't know if you're still on the call.
I am still on the call, yes.
Perfect, thank you. So I don't know if you're happy to answer this one, but I'm obviously happy to pick up as well about where we go with independent. So do you think that the inability to independently prescribe will limit the scope for dietitians?
So I suppose supplementary prescribing obviously means that we need to use clinical management plans. And I think that some of the challenges with clinical management plans comes from the fact that most dietitians are trying to use them within community and acute secondary care. But actually, some of those issues that we have with using clinical management plans do disappear when you're sat in with the GPs in primary care. And also, the clinical management plans allows you to have those conversations with the GPs. I think, what we need to be mindful of in primary care is that it can feel a little bit isolating potentially. So the fact that you can use clinical management plans allows you to have those conversations with your GPs, lets them know what you're capable of, and also it becomes a two-way learning thing. So do I think it's limiting in primary care? Absolutely not. We can work around those barriers associated with the CMPs. It is more limiting in community and secondary care. But at the end of the day, prescribing is really about primary care. That's where it works best. I don't know if you want to add anything to that, Eleanor?
Thank you. Nothing in terms of the limiting factor. I think you've answered that perfectly. The only thing I will add is just to make people aware that we are doing everything we can to lobby for independent prescribing. We know that it's limiting, especially like Tanya said, in terms of community and acute care. So we are speaking to ministers along with 4 other professional bodies, and we're lobbying ministers to say, look, this is really important. Can you please get it on your agenda? We're raising the awareness with them. In order to become independent prescribers, we need another change in the law, and it has to be driven by NHSE and I. It then gets shared with the devolved nations. So once that decision is made with government, it will then pass on to Scotland and Wales as well. The only country that it doesn't, because of the devolved nation, is Northern Ireland, and we're also supporting Northern Ireland to work through this as well. So in terms of independent prescribing, we've recently responded to an NHSE scope to say, why do we need independent prescribing? Why is supplementary not working? They were very open and honest with us at the start, and they said there is no money to move this work forward at the minute. All we're doing is scoping out what are the issues with all the professional bodies. That report will then go to NHS E&I, and they'll make the decision in terms of, is there any money to take this forward, and which professions should we take it forward with. So we're doing everything we can, and we are lobbying ministers with other professions. So please note that we're not, just accepting staying at supplementary prescribing. We know that we need to push forward for independent. Steve, one for you. Is the NHS pension protected in the same way if you're paying into this as an employee of a PCN?
I believe PCNs are allowed to provide the NHS pension scheme. Yes, any even private companies can get the authorization to do that. So yes, the PCN can apply to be able to provide the NHS pension scheme.
Thank you. We've got another question. Has the willingness to support the development of these roles, i.e. the willingness of GPs, been scoped? I'm going to go over to Amanda, but just to share with you some of the stuff that we're doing. We have conversations with NHS and Confed to try and raise the awareness of GPs that way, and other healthcare professions. And also we've had conversations with CQC to look at is there a way of increasing nutrition in CQC recommendations. So again, none of this is promised, it's just initial conversations, but then that helps to raise the awareness. And also we sent our guides to GPs to RCGP and have asked them for their endorsement. So we're just waiting to hear back from that. We've also had some involvement from the GP Interest in Nutrition group. Again, they've given us some really good feedback in terms of how do we raise the awareness of what dietitians can do in primary care with other GPs. So we've got lots of avenues to explore there to just increase the understanding and the awareness. But in terms of some of the initial willingness from GPs, I'm not sure, Amanda, can you answer that from a HE perspective?
Yeah, for sure. There are GPs across the country that are interested in dietitians moving into primary care. The biggest plea I get is, can you please tell us what they do? And they want to know what your offer is, and it's really, really important. It's important for all of you dietitians. It's all of your responsibility to help to raise awareness amongst the PCNs. It's not just up to Eleanor and Steve and Tanya to do it. It's up to all of you to go out there and say, I'm a dietitian and this is what I do. This is what my profession brings to your practices. So it's really good. But from an HE perspective, so we have the landing page. And on the landing page, there's a drop-down box that says what's the skills of our professions. And in there, we've got a direct link to your primary care webpage or the BDA. So we're raising awareness, and if you're on Twitter, can you please retweet what's gone out today about the landing page? The more that people know about the landing page, the better, because it's a central source of truth for FCP and AP in primary care. So we've got that on there. Eleanor's coming to a meeting this week. Thank you, Eleanor. Our Advancing Practice stakeholder group that has all of the regional primary care training hub leads there. It has the Advancing Practice faculty leads, and it also has the primary care regional NHS England primary care leads there as well. So she's actually going to be presenting to all of them about what dietitians can bring into primary care, and then those minutes will be written up, and that will be sent across again with a reminder in the landing page to everybody that they send it out through all of their networks and all their channels, and that should go down to PCN level. We also have our AHP HE webpage that also describes what dietitians do. I'm hoping to tidy up the primary care webpage as well to make sure that everything's on there. Lots of tweets will be going out on the run up to your roadmap being launched, just to make sure that everybody's aware of what your skill sets are. So I think that if all of us club together and we're all out there working together to show exactly what an amazing profession you are, then you'll get recognised for your work. And I know that, Tanya, you'll realise, won't you, with working in primary care, it doesn't take very long for them to cotton on what an asset you are, does it?
Absolutely. So like Amanda says, just get out there and let the GPs know what you can do.
Thank you. I think as well, you know, going back to the reason that the roles were developed were to increase the capacity of 50 million more GP appointments by 2024. And so, you know, they are on their knees, you know, like a lot of healthcare professionals in the NHS at the minute. So going in there and being able to increase their capacity with these first contact roles, where we can say, look, actually this is our expertise and we can really support you here, and that helps to enable them to then deal with more complex cases. So it's showing how we can be an asset to them, like others have mentioned. There is also the question in there about the willingness to support the development of these roles, and some of that will also be supported by other AHP colleagues. So when Amanda mentioned about the supervisors, they're multi-professional. They don't necessarily have to be GPs. They can be, but they might be a physio. So they're supporting you with roadmap capabilities and being able to put that into practice. So it doesn't have to be profession specific there, and it doesn't have to be a GP. So in terms of capacity, other healthcare professionals in primary care will be supporting the supervision of these roles. We've got another question. Where do you do the mandatory modules in stage 1, please? Is it the e-learning for health portal or the personalised care institute? Thank you. It's both. Amanda, are you going to say?
Yeah, it's a bit of a nightmare. So yeah, it's both. So the 8 primary care e-learning modules are on e-learning for health, and the personalised care modules on the personalised care institute. So people, we might as well say this now. So you'll see that the e-learning modules are quite MSK based. The primary care, there's a lot of generic primary care stuff in there as well, but the reason it's MSK is because 40%, up to 40% of GP consultations are MSK. So you will definitely, as a dietitian, get someone in that has an MSK related issue. And in terms of dietitians, you know, that could look like poor nutrition, you know, as part of the problem towards somebody who's got osteoporosis, for example. So it's not irrelevant to you to do those modules, and it's really important that people do that, because also recognising if they're talking, because patients do check, it's a real privilege to be in primary care because you get to know your patients. It's not like in secondary community care where you may see somebody once and never see them again. You see them time and time again, and you're managing their care in the community. So if they were to come in and, for example, they say you've got a bad back and saying, but it's really weird because I was unable to hold my urine this morning and I didn't know I was weeing myself, then you as a dietitian would need to be able to pick up cord equina, because it is the biggest problem in primary care of that being missed. So it's really important that we raise the awareness for all of the professions for MSK, but it's not just MSK modules in there by any means, but it has got an MSK slant in. I know that it's going to come up in another webinar at some point. So I think if we say it now on a recorded webinar, we know that. And the personalised care module is relevant to everybody. Personalised care is what we do in primary care, and the rest of the you know sectors as well, but particularly in primary care, it's super duper important to do that. At the moment, the personalised care, the correct link is on the web, on the landing page.
Thank you. And also I mentioned during the slides that we'd commissioned one of our members to review the modules, and she's made lots of suggestions and recommendations for not just those 8 core modules, but actually lots of others that we might find really helpful. So we are going to update our website and have a specific training and education page. So over the next few weeks, just look out for that training and education page, which will signpost you to both of these, but also some additional training that you might find helpful. So we've got another question. What will happen if you are in an R's funded post but don't want to become a first contact practitioner? Amanda, do you want to take that?
I will do. No, you don't have to become one, but it's good practice to become one, to be honest. It's good practice to do the training, because then you can prove capability. In primary care, it's a really high risk environment. there's a lot of uncertainty. You have lots of complex comorbidities and everything. You should really be working at master's level, particularly if you're a lone worker and you're not in the support of the whole dietitian pathway. It's really, really important that you do upskill and do that. I guess the other way of looking at it is, for our HCPC registration, we have to prove that we're doing CPD anyway. So I would recommend that you use the roadmap as a focused CPD, because it's focused on primary care, so it's relevant to you and your training. So I think that it would be advisable to do the roadmap, even if you are already employed in primary care, for sure.
Yeah. Again, with the R's funded posts, the requirement is that you'd be at advanced practice level, and so it's a way of showing that advanced practice clinically. So you're not expected to be at advanced practice level for the in all 4 pillars. For the first contact practitioner is in the clinical pillar, and that's where your roadmap will highlight to, you know, how do you prove that advanced practice in your clinical pillar. To then become an advanced practitioner, it would be a level 7 in all 4 pillars of practice. So again, that differentiates between the clinical pillar and then the rest of the pillars to top up to a advanced practitioner. Again, it's the similar question. So is the expectation that as a PCN dietitian that you'll have to do the FCP training, or will it be optional? Again, it's about that advanced practice and being able to recognise that, and the roadmap being there to support that, and also to support your safety and the patient's safety, that you're competent to do those specific roles. We've got some thank yous. Someone asked about the national trainer. Do they contact Denise Virgo directly? Yes, that's right. Will the PCN roles be expected to develop into FCP roles, or are PCN dietitians different and will remain so? I think the words are kind of PCN roles, I think, have come about because of this additional roles reimbursement scheme in the GP contract. But yeah, the FCP roles are, the roadmap for FCP roles are there to support those exact roles. Yeah, they would be the same thing. Again, you know, all of this work's going in to look at what other training and education requirements are available and there, and it helps us as a profession to progress, but also make sure that there's the safety element is behind that, and the right competencies are achieved in order to ensure safety for everyone. I don't know if anyone else wanted to add anything to those questions. My PCN is set up by a private company, and currently I'm freelance as pay wasn't set up. I'm due to cover both peds and adult. The company aren't aware of the BDA and how they're supporting PCN dietitians. They feel my role should be pretty much 100% clinical, similar to that of a GP. Is there any document I can use to support and how the role of the dietitian differs? Thank you. As the BDA, we could only make recommendations, and we'd made, you know, it's up to that PCN whether they take that on board. We've done a guide to GPs, so we made a recommendation in there that these roles, as Amanda said, should be in line with like the advanced practice apprenticeship standards, which is 80% clinical, 20% CPD, to allow for, you know, development, but also to make sure that you are achieving CPD and all the supervision that is required for your HCPC standards. So that document may support you, but again, it's only a recommendation. I don't know if Steve and Amanda want to come in at this point as well. So it wasn't Steve yet.
Yeah, I from what you said when you read the question, it said the person, I believe, is freelance or
yeah.
So technically they're self-employed, so they're their own company. So therefore they determine themselves what training they do. They'll have a contract with the primary care network to provide a service. They're not employed by the primary care service. They are self-employed.
Yeah, so in that sense, the CPD would be in their own time if that hadn't been agreed with the contract when they set that up with the company.
They would negotiate what their time they have, but as they're self-employed, it is for them to determine what their CPD is and what they need. But they are not actually employed by primary care network. They're self-employed, so they just have they would need to negotiate with them what they want them to do.
Thank you. And
Absolutely.
sorry.
What I would is that if you are self-employed, please don't work in silos and in isolation. You need to make sure that you're working across the whole care pathway. It's not good enough to just come into primary care and just work in a silo. It won't be nice for you as a clinician. It's not great for your patients, and we are moving into ICSs now, and we really need to start working in an integrated kind of way.
Yeah, thank you. And anecdotally, you know, when I've heard from dietetic managers, they really welcome people going and speaking to them. So even if you've not been employed by the trust, I would really encourage you to contact them and have the conversation, see if you can set up a meeting and talk about how you can work together. Is there any members of staff there that you can access some CPD from? Obviously, the supervision that will be available in primary care will be available to you, but are there any trusts that you can get in contact and work collaboratively with? And also just to help to make sure that services aren't duplicated as well. So yeah, I echo what others have said in terms of not working in isolation. What happens if a clinician doesn't go through the roadmap? Does it affect reimbursement? How would this be monitored? So if a clinician's not able to evidence advanced practice, that they're working that advanced practice clinical level, then yeah, in theory, the role wouldn't be reimbursed through that government funding stream. And the roles in primary care are monitored. NHS Digital do have statistics in terms of who's employed within these roles. Is there anything else to add from anybody else? What impact do you think FCPs will have on community dietetic services, both adults and peds? Tanya, I'm happy to answer, but I don't know if you wanted to answer this one.
I mean, I think the main thing I would say, which has been said throughout the webinar, is the aim of these roles is not to duplicate what is already out there. It's about putting the right person at the right time in that patient's journey. So potentially what these dietitian roles are doing is they're making sure that it's an easier access to see the right clinician in primary care. So rather than the GP doing a lot of the pre-work before referring on to your community or secondary care dietetic services, you've actually got the dietitian doing that. But it's not intended to duplicate. There's absolutely enough work to go round, but we should be streamlining our pathways, which is why it is so important that we all work together across the health economy to make sure that we are making the most of the resources that we've got. And I think, you know, just to reassure people, primary care can be a really supportive environment. So it is just about that two-way communication, and for dietitians just to grasp the opportunity that has been presented to them, because I think this is a really exciting opportunity for dietitians. For a lot of time, we've sat in our secondary or community care services and thought, well, if we'd have just seen this patient potentially 6 months beforehand, or if we just got involved with this person earlier on in their diagnosis, we could have made a much bigger difference. And obviously this is the opportunity for us to do it. So although it can be quite overwhelming, this change, it is very exciting. So we just need to grasp it, really.
Thanks, Tanya. Steve, were you going to jump in there?
Yeah, it's slightly outside of what we're dealing with today, but I have been advocating at the social partnerships that I would love to see the primary care networks representatives coming into the social partnership, the regional social partnerships, where you've got senior people from NHS trusts and things like that, sharing experiences and supporting each other. So in other words, it'll be top down rather than as well. So I think that's the way forward, but we wait and see whether that happens.
Definitely agree. Yeah, absolutely. And we've got here, when working on our own as a practice dietitian, how can we link in with local dietetic services? And I think that's, you know, what we've echoed and kind of answered already. I would say pick up the phone, send them an email, just Google them. You'll find their phone number, give them a call. I'm sure they will be delighted that you've got in contact, and then you can look at what services are out there. How can you refer into their services? At what point should you be referring into their services? And also, you know, they're going to likely, if they're acute service, they're going to have links with those consultants that you'll be referring on to potentially. So, you know, it might give you the opportunity to get to know those a bit better. If you're writing to the gastroenterologist or, you know, you've got a two-way conversation with them, it's so much nicer when you know who they are. So yeah, pick up the phone, I would say, or drop them an email and start those conversations. Any other tips from anyone else?
Yeah, you see, I like that, Eleanor, because what Eleanor's demonstrating there is master's level practice, communication skills, showing creativity, solving problems, and taking initiative. That they're all the things, all the attributes that we're absolutely looking for of people working at a master's level. So yes, don't wait for someone else to join it up for you. Reach out to others, offer to do in-service trainings for them, offer to take their students. It goes a very, very long way.
Yeah, brilliant. And also we need more dietitians in primary care, you know, absolutely in the future. So get students involved now, get them keen on it. They can then start their pathway earlier, and we're giving them the best opportunity to know the roles that are out there and the experience that they can be gained, and, you know, keeps them in our profession and keeps them interested. I know that when I was training, if I'd known about roles like this, I'd have jumped on the chance to go and have a placement in primary care. Can you be both a paediatric and an adult FCP dietitian? And we would say it's very unlikely that would be the case. If we're dealing with undifferentiated diagnosis in paediatrics, you're going to have master's level specific training and education in paediatrics. You might have that in adults, but actually it's unlikely for that to happen. Yes, we can pick up spectrum. You know, if someone's already been diagnosed, you might have a dietitian working in adults, and then they've also got knowledge in cow's milk protein allergy in paediatrics, and they might be seeing children through that capacity. But for these first contact practitioner roles where they've not seen anyone before, it's unlikely that you might have the skills. It's unlikely that we're going to have a dietitian that's covering both adults and peds. For that reason, we have split them out into different core areas, and paediatrics being its own one. So we're not saying it's impossible. Someone might have those skills, but we just want to make other clinicians aware that if you've always specialised in dietetics in adults and you don't have master's level qualifications in paediatrics, you couldn't be picking up you know, a child that's presenting at the GP practice with undiagnosed conditions. Would you agree with that one, Tanya?
Yeah, absolutely. And in the future, like you've said, Eleanor, there may be that we make changes to the way that dietitians are trained that enables people to deliver both adult and paediatric care. But as a profession at the moment, you generally train either as adults or paediatrics.
Yeah. Watch this space for the future. We've got a comment here, just to add to Eleanor's response about acute dietitians treating holistically. I would also agree that they do this, but a patient who walks into primary care and meets an FCP dietitian has not seen a doctor, whereas a patient in acute trust generally has. The focus for training the FCP and AP dietitians must ensure they can also pick up red flags. So completely agree with that and comment, and Tanya's nodding as well, is that the difference here is that you don't have, this person hasn't already been diagnosed and you're the one picking that up. yes, in secondary care, you might notice that actually they've been diagnosed with this, but it doesn't fit well with that condition because you've got a great awareness of that. Your advanced practice in that condition, and you know that something's not right, or that there's something else going on, but you don't diagnose that. You might, in very specific circumstances, but you'd usually hand that over to the medical team, who would then look into that. So yeah, that comment, I really agree with that comment, definitely. I understand that PCN dietitians should be working at an FCP level, but it would be good to understand if the training is optional or whether the expectation is that the dietitians have to do it. Hopefully we've answered that already. So the framework is there to cover the competencies to ensure safety. So we'd absolutely encourage people to follow that as a way of evidence in your advanced practice, and also as a way of obtaining support to do that, because the supervisors are out there to support you along that journey. And obviously we are working with HE on this, and we'll be highlighting the training development needs, and looking at, is there options available for funding for specific courses that might be useful for these. So we will keep people updated as and when, and there are any developments with that. At the minute, if you identify needs, and see if Tanya and Amanda, are you in agreement with this? If you identify a specific need, training need, and there's a specific course that you think would be helpful, I would signpost you first to your primary care training hub. And speak to them about, is that, what's available in terms of supervision and support there. Is there any funding available? Obviously, our roadmaps haven't come out yet, so we don't need to find supervisors to support us with them just yet. That's once they've been published. But yeah, would you both agree in terms of going to your training hub first?
I suppose I'd say talk to the PCN as well first to see whether, we say training or study, but actually if you're working in primary care, there's a whole MDT there. And I think one of the things that we need to remember is these roles, you should be at that advanced level of clinical practice, top of scope of your clinical practice. Therefore, it's not necessarily the dietetic specific training that you need. It's about taking those skills that you have from working at that level in community or acute and actually putting them into primary care. So the bit that's different is how do you take your skills and adapt it with primary care. So that might be that you're spending time with other people within the MDT, and you'll learn a lot by spending time with GPs, with advanced nurse practitioners, the physio, the pharmacists, so the social prescribers, using the people around you. And actually, if there's still knowledge gaps that need to be addressed, then potentially that's where your training hubs can support that. Amanda, do you want to add anything to that?
Yeah, I agree with you completely, Tanya. And yeah, your training hubs are responsible for FCP training. That's what they're there for. That's your go-to for AP training, and from FCP to AP, that's your advanced practice faculty leads that are responsible for that. In terms of FCP modules, just on the side, if we talk about the taught route, if you wanted to go and do an FCP module that completes both stage 1 and stage 2, there's going to be some funding for modules this year for dietitians. We're running a HEI FCP module national webinar on the 31st of August. I know that the BDA will be attending, and all your dietetics universities will know about this, so that we can make sure that we have got some tailored FCP modules for dietitians to be able to attend. And we hope that we'll be able to provide you with some free funded places for that as well.
Thanks, Amanda. I think that really ties into the next comment as well. We've answered most of that. So if PCN dietitians working under the reimbursement scheme are practicing as FCPs, how do we develop the skills needed to diagnose and treat at that first contact? Those skills can only be developed through supervision, and if the PCNs don't recognise or want to do that, how can that be done? So absolutely, you've got your access to your supervision once our roadmaps are published. And then there are specific first contact courses. So if you Google first contact courses now, there are some multi-professional ones. We have one dietitian that's already done that course, and she says it was really helpful. It helps to identify the physical assessment, but also the red flags when we are seeing these patients, and that answers the question of how do we develop the skills to diagnose. So courses like advanced physical assessment, and we've identified as being important for these roles, so we can do that physical assessment, but also the first contact roles. And as Amanda mentioned, we will be considering doing specific dietetic first contact courses, and then, you know, is that something that we need to develop in future?
Yeah, it's
I
really,
think
I think Steve wanted to say.
Yeah, I'm because it sounds as though there will be people taking up jobs in the primary care networks that haven't necessarily got these qualifications, and will be working towards it. Now, that may well be a contractual term that, yes, you can have the job as long as you do these courses. So it might not be down to the individual whether they want to do it or not. It may be a contractual requirement.
Yeah, thanks, Steve. And then it's for that dietitian and the place of work to look at what time frame suits, isn't it? Yeah, thank you very much. Tanya, were you going to come in on Amanda?
Go on, Amanda. We might be saying the same thing.
Right, because that's what's happening. You know, with physios in particular, is that they're taking them on, and then but on interview they have to agree that they'll do the FCP module, which is great because you know, if you're already a dietitian in primary care, why not go on an FCP module? Do you know what I mean? And the really beauty of it is, as soon as you become an FCP, then you can become a roadmap supervisor, and then you can help the next lot through the portfolio route.
Thank you. Tanya?
I mean, the only thing I was going to add is really the FCP roadmap it's almost trying to target your professional development and looking at where your gaps are. So by moving from acute or community care, you are going to have gaps in your knowledge associated with that move into primary care. So the roadmap is really a supportive document to help that transition. So yeah, why wouldn't you want to do it? It's a supportive document. It's not meant to be a it's not meant to be anything other than a supportive document.
Yeah, definitely. Yeah. Yeah, it's not, I think as well, Amanda mentioned right at the start about it being there too. It's not trying to block anyone. It's not trying to devalue us in primary care. You know, we are absolutely valued by the healthcare professionals, but it's trying to showcase the extent that we can work, and, you know, what does it look like for us to work at advanced practice level in dietetics in primary care, and show others as well as ourselves. I am just conscious of time. We've got 4 minutes left. We seem to have loads more questions, which is amazing. It's great to have so many questions. I'm guessing we won't be able to answer them all, but the ones that we can't answer, we will answer outside of the webinar, and then we will post them on the website. We've got a question here. Can you tell me a bit more about how community dietitian services working in NHS trusts can engage, work with PCN to employ dietitian through an SLA, or however does it work? So Steve, I don't know if you know more, but my understanding is that so a primary care network may or may not already want a dietitian. You might go to them with the you know, this is what we can offer you. You could develop a service level agreement, and then you would be saying, look, this is what we can offer a dietitian for X amount of time. You're agreeing that with the PCN. You're showcasing what we do. You might need a bit of an elevator pitch before that, selling dietetics to them, and then you have an agreement with that PCN to offer that dietitian on the terms and conditions outlined in that service level agreement. Steve, were you going to do it?
Yeah, I think that there's three possibilities. One is that the PCN itself is employing somebody, so you will become an employee of that primary care network. You will have all your terms and conditions agreed with them accordingly. So and they will be responsible for you. There may be that the primary care network will seek another organisation to lend them a dietitian to do the work. That's by a service level agreement. You'll be employed by the home organisation, say a trust, for example, or where you may be a freelance self-employed dietitian and you have an agreement with the trust, with the primary care network to go in and do the work. All those models fit up, but your actual terms and conditions, i.e. your contract, pay, annual leave and all that, will be determined by the organisation that employs you. And if you're self-employed, that's yourself.
Thank you. I
So
get the impression.
Part of that
Sorry,
question was probably about engagement as well, was it, Eleanor? So, you know, how can community dietitians engage the PCNs to say, you know, this is what a dietitian can offer? You can Google all the clinical directors. The PCN contacts are freely available, so you should be able to get hold of those. If you can't, then you know, use your dietetic manager, your therapy services manager. And I think a big part of this is about getting yourself out there and letting PCNs know what a dietitian can offer, because they will have a lot of assumptions. You know, dietitians may have been quite distant to them, being in community settings. So it's just getting out there and telling them what a dietitian can offer them.
Thanks, Tony. Yeah, I get the impression, I might be wrong, but I get the impression this is a community dietetic service that are looking to employ a dietitian through an SLA. I might be wrong, but yeah, exactly that. Sell yourselves to the PCN. The guide to general practice that we've got on the website is on the landing page of the first contact practitioner one on the BDA site. Guide to general practice. In there is loads of stats of what we can offer in primary care. So, you know, just absolutely steal those and just put, you know, with permission from the BDA, we'd be more than happy for you to use that content that's in there, showcasing what dietitians can do. If you need to put a business case together or a few slides, please, you know, use that content to do so. The feedback that I get from GPs is, how do you save us money? So how do you make us money or save us money, and how do you reduce time? So, you know, that first contact role can really support with that. If you have supplementary prescribing, if you've got a dietitian that you're thinking about doing supplementary prescribing, that can be really beneficial. QOF points, that's what we're looking at the minute. Quality outcome framework, how can your dietitian support that PCN to lead on some of the QOF points and sign some of those off? So you're really having to think strategically. Of course, patient care is hugely important and benefits and outcomes to patients. So you probably want to have a mixture of all of those things as a selling point for these roles. Oh, we're out of time. We're 31 minutes past, so I'm sorry. I know people are starting to leave the webinar. We will absolutely respond to all your questions. So as I said, we'll take those away and we'll put responses on the website. Thank you all so much for attending. It's been great. We've had brilliant questions, but also thank you so much to Steve, Tanya, to Sue and to Amanda, who've spent their time to come this evening to support with this, because obviously you know, we need a whole team behind this and lots of support from others. So we massively appreciate everyone else's time to help to answer these questions and to help to support all of these roles in primary care, and making sure that people are aware that the BDA are here to support you and absolutely want to answer the questions that you have and be as helpful as possible. So thanks to you guys that have also helped to present this evening. And good night to everyone.